So thank you all for having me here today to speak about fatigue and ITP, which is a very important concern. So to begin, I went to the dictionary and just looked up fatigue. And the dictionary definition of fatigue is extreme tiredness from mental or physical exertion or illness. But I found another definition that I liked a little bit better, that was feeling overtired with low energy and a strong desire to sleep that interferes with normal daily activities. And I like that because I think it gets to the heart of why fatigue can be such a bothersome symptom to have to live with. But really the best definition of fatigue is one that I learned from you all at the conference, I guess it was 2 years ago, and that is that fatigue is essentially being out of spoons. So we are out of spoons and we don't have enough spoons to get through our day. And this concept was one that was first brought about by a woman who was suffering from lupus and was trying to explain what her fatigue felt like to a friend, and they happened to be out at a meal. So she brought up the visual of spoons, and she said, each of us starts our day out with only a limited number of spoons, and each activity we have to cash in some spoons. And for most of us, we have an unlimited supply. It never runs out and we can get through our day without any problems. But for somebody suffering from fatigue from a chronic illness, their number of spoons is limited, and eventually they run out and they've reached capacity and they have no more spoons to do the activities they want. And imagine even living with a chronic illness in which you don't get a good night's sleep. And so then you start your next day with even fewer spoons than you already had in your limited pool. And I know a lot of you have used this kind of spoon analogy to describe how fatigue makes you feel and how it interferes with your daily activities. The other problem with fatigue and chronic illnesses is that because it's really difficult to define, it's often not recognized by physicians. It's subjective. It's not like a blood pressure, for example, where we have a very concrete number to work with. It may be very different for each patient. It's also quite common in the general population. And so for that reason, it's something that maybe gets dismissed or not recognized as a symptom of the disease itself. It's not easy to measure. I will bring about in the next slide coming up some of the measurement tools that are out there, but it's not easy to quantify it or to put an amount to it. And we don't have any magic treatment. Once we identify it, then sometimes we feel it's very difficult because we don't know what to offer a patient or how to make it better. Fatigue has really gained appreciation, though, because it's a recognized part of current assessment work being done in health-related quality of life. So many quality of life measures would include at least a question, or in the focus group component of building those measures would have a component of fatigue, and it really brought this to the surface. And we've got new methods always undergoing a development to look at how to quantify fatigue to make it something that's more tangible to wrap our heads around. And then also we're gaining some insight into the mechanisms of fatigue and chronic disease. And I'll show you one model of that in this discussion. So when talking about fatigue, there's really two different kinds of fatigue. We have peripheral fatigue, and this is the fatigue that most of us feel after, for example, going on a run. It's overuse of our muscles, and it leads to a feeling of weakness. But we also have centralized fatigue, and this is a bit different. This is really generated by the central nervous system, and it results in a difficulty in performing physical or mental activities, and it leads to a higher perception of efforts to accomplish a similar task in our daily lives. And this may be due to important changes in the chemicals in our brain that trigger that sort of sense of perceived effort and or sense of exertion and tiredness. In this concept, when we talk about fatigue and chronic illness, one important piece is fatigue really disease specific, or is it more a symptom that's very general to many chronic diseases, similar to nausea? And I think this becomes important when we start to think about how to treat it or how to think about it or learn about it, is really looking at chronic illness in general, and then how can we apply that to ITP and what can we learn, even from outside our own community. So we do have some ways to measure fatigue. The first is the fatigue impact scale. This is a 40-item questionnaire that assesses how fatigue impacts cognitive, physical, and psychosocial functioning. The ITP PAQ is more of a health-related quality of life measure, but it does include a question: how often in the last 4 weeks did ITP or its treatments cause you to be physically fatigued? We have the functional assessment of chronic illness therapy score. This has 13 questions related to fatigue embedded in the bigger measure. And then for pediatrics, we have the Hockenberry fatigue score that has either 10 or 17 items that are completed by the parent or the child. And the number of questions varies on the age of the child or whether the parent is completing that. And this was really designed for cancer therapies in children, but has been used in some pediatric work surrounding fatigue and ITP. So fatigue and ITP, I think, kind of again came to the surface in working on these health-related quality of life measures. And in the focus group work that was the foundation for developing the ITP PAQ, 93% of patients in the focus group reported fatigue as a symptom. So it was clear that this was a really important component of living with ITP. A subsequent survey reported 12.5% of patients reported always or often missing work or school secondary to the symptom of fatigue. A larger study was done in both this group and the Oklahoma ITP registry, and what they found was that a fatigue impact score greater than 40, which was defined as severe, moderate, or severe fatigue, was seen in 39% of respondents from the UK ITP Support Association and 22% of respondents in the Oklahoma registry. And this was much greater, significantly greater than in the general population, where we see this in only about 2.5%. So while fatigue may be quite common in the general population, this sense of moderate and severe fatigue is actually quite specific to living with chronic illness. 82 and 50% of respondents from both groups reported energy changes with the onset of ITP, so clearly linking the disease to a change in how they felt. And 69 and 50% reported lower energy when their platelet count was low. Fatigue is also still present in patients with a platelet count above 100,000 is what they saw. So that link between severe thrombocytopenia and fatigue may not be the sole source of what we're looking at. And there was an association with a low platelet count, bleeding, other medical conditions, the symptom of daytime sleepiness, the presence of what's called orthostatic symptoms, so an inability to control the blood pressure with positional changes, and female gender. So maybe starting to, with survey data anyway, identify some of the things that may be a component of fatigue in ITP. ICON 1 was a long-term study that we did in pediatric patients that came out of the Pediatric ITP Consortium of North America. And in this study, patients had fatigue assessments prior to starting any second-line therapy, and then at 1 month, 6 months, and 12 months while on that therapy. And shown here is just the baseline data, but what you can see is that at baseline, 42% of patients had moderate or severe fatigue, 30% at 1 month, and 27% at 12 months. So a slight decrease over time on the treatments. It also shows in this graph here that regardless of whether a patient had newly diagnosed, persistent, or chronic ITP, moderate to severe fatigue was quite common in all those groups, whether we were looking at the child themselves, an adolescent, or the parents serving as a proxy for their child. In clinical trials, in the Remipplestum study, there was one that used the baseline ITP PAQ, and fatigue was among the 5 worst scores on that health-related quality of life measure. In the Althrombopac RISE study, the FACIT-F score was lower in ITP than in the general population, indicating a greater degree of fatigue. So baseline clinical data from clinical trials matches information collected by survey data and longitudinal studies. And this really all supports the concept that fatigue is a significant symptom of ITP. So I really like this diagram by Drs. Hill and Newland that just shows the complexity of what we're looking at when we start to think about why ITP might result in fatigue and what could be going on. And it really is quite complex, and I'd like to break it down and just walk through kind of each of the different components. What we know about ITP is that it's caused by changes to the immune system, and these changes produce different chemicals as a response and also inflammation, and these chemicals are called cytokines, and they're part of the driver of our immune system and inflammatory response to different things. With ITP, we also get a low platelet count. This low platelet count results in bleeding and bruising symptoms, as well as activity restrictions. If the bleeding is significant, our patients can have anemia and even iron deficiency. And these can lead to fatigue in different ways. So anemia and iron deficiency can have a direct impact on fatigue. If our red blood cell count is low, we are going to generally inherently feel more tired. Iron deficiency can make us feel more tired. But then there's also the impact on our social structure, on our activity level, on our ability to engage in our normal daily activities from either bruising or bleeding or activity restrictions that can secondarily result back in some feeling of fatigue. Some patients, not all, but some patients with ITP also present with either an underlying disease, so secondary ITP, or other comorbid medical conditions secondary to things that they had prior to developing ITP, as well as other factors that may predispose them to being more prone to the development of fatigue associated with ITP. And so it's always important to recognize those during an initial diagnosis of a patient with ITP to really make sure that we're supporting the entire picture of what is occurring medically. Some of our therapies may work against us in the category of fatigue. And I am speaking to you all as the experts on side effects of corticosteroids, but as you know better than I do, corticosteroids can be very disruptive to sleep patterns, as well as have side effects of depression and anxiety, all again, which can contribute greatly to the feeling of fatigue. And I'd like to really spend most time on this component right here, which is what we know about the biology behind fatigue. So this concept again of inflammation, cytokines, the way the periphery interacts with our central nervous system and therefore results in the feeling of fatigue. And what do we know and what do we still not know? Most of this work, the greatest body of literature surrounding this, has really come from work in chronic liver disease. So this is the model I'm going to show you, but you can imagine where this diagram has liver inflammation, we could be talking about inflammation or immune dysregulation in any part of the body, not just specific to the liver, assuming that the process is going to be generally the same. So what's happening is, as you can see here, we get these cytokines that are released. So these are those chemicals I was talking about that come about in response to the immune system seeing changes. We also get activation of the immune system. So our immune system is not in balance, and we're getting overproduction and underproduction of the different important cells. These immune cells can go directly into our CNS system, again, producing cytokines and interacting with different components of the brain. The cytokines can also travel via a nerve route or via a humoral route to our brain as well. And again, these cytokines then relate to changes in our neurotransmission. And what that means is we get a change in the different chemical balances that are occurring. And these chemicals are really important to our feelings of happiness, to our feelings of tiredness. And any slight adjustment to that can really alter how we feel in terms of feeling motivated or feeling rewarded or getting that spark of that happiness or feeling as though an activity is perceived to be much more difficult than it used to be. And again, collectively, all of this then results in a feeling of fatigue. So I think it's important to recognize that there's a lot of external things that can lead to fatigue. There's a lot of other symptoms and things occurring, but it may also be that inherent to the disease process itself, there's a pathway that's leading to fatigue as well. And this may be common to multiple different chronic illnesses, not just specific to ITP. So what are the effects of our ITP treatments on fatigue and the symptom of fatigue? And I think we can have a lot of potential positives from treatment. We can get an increase in the platelet count that might help. We can see a reduction in our bleeding symptoms. We may be able to increase activities if our platelet count goes from being very low to very high. And I can tell you, as somebody who manages a lot of teenagers, this concept is very important to keeping a teenager active and engaged. And maybe some of these medicines also reduce that process of inflammation. So again, causing that reset in the system that initially caused all the downstream changes that led to a chemical feeling of fatigue. There may also, again, be some negatives. We've talked about corticosteroid effects, anemia and then immunosuppression in general, and maybe they may work against us instead of working in a positive manner to handle our fatigue. So when we think about the impact of treatment on fatigue, again, one positive would be an increase in the platelet count. In the ICON-1 study, so again, a study of pediatric patients, children starting as second-line therapy, we didn't see a big difference in change in fatigue between responders to treatment and non-responders to treatment based on just a platelet count. So simply having a platelet count go up on treatment did not necessarily fully address the symptom of fatigue. There was also no change in fatigue seen with a lot of the clinical data that came out from the TPORAs, despite those drugs clearly demonstrating a response in platelet count. We can also look at bleeding symptoms. So again, this concept that perhaps if our bleeding symptoms are significant and leading to anemia, or even if it's just bruising, but interfering with our social interactions or causing distress from the appearance of bruises, that may also have an impact. If we can improve those symptoms, then perhaps the fatigue would also be alleviated. Again, looking just at ICON-1 data, so this is pediatric patients, fatigue scores did not correlate with bleeding symptoms. So it seemed like fatigue was not dependent upon how much bleeding you had. So some patients had no bleeding, but very large degrees of fatigue, and vice versa. Again, if we look at our TPO data, which is some of the bigger clinical trials that have collected a lot of very good patient-related outcome information, there was no change in fatigue seen with these drugs, despite again showing an improvement in the bleeding symptoms that patients were experiencing. It may just be that we're not asking the right questions, right? It may just be that the measures and the tools that we have to assess these different things aren't enough to connect the links or to really understand the interactions. So this may not be the full story. It's just the only part of the story that we have right now with the information that's available to us. But again, another component of this may simply be, maybe you don't have to have a full response. Maybe you don't have to have full improvement in your bleeding symptoms. Maybe it's just enough that you can go back to increasing your activity level. Energy can improve even with very small increments in activity changes. Again, critical for social interactions. If you talk to teenagers that are very used to being engaged in sports and sports teams and now all of a sudden cannot be, that's hugely detrimental to their social structure. And I think is a large component of fatigue, depression, and other symptoms that are downstream from that. And I think we really need to be aware of that. Also, reduce stress and anxiety about work and job interruptions or disruptions, even with just small changes in the ability to have a reduction in bleeding symptoms or some other changes. And I think sometimes when we think about therapy, we're really tied to treatment because of the platelet count. But these are other reasons to consider treatment, right? If we can just get somebody's platelet count high enough, even if it seems like it's good enough, if it's not good enough for them to continue to engage in their normal activities, if it's not good enough for them to combat fatigue with positive social structures, then maybe that alone is a reason to consider a form of treatment. And I can tell you with the ICON-1 study, we also did ask why patients were getting started on second-line therapy. And a lot of times it wasn't because of bleeding or the platelet count, but it was more because of their quality of life and the fatigue that they were experiencing, and to try to get them back to that and to maintain that in a really important way. So in other conditions, I use the model of liver disease, but in other conditions, markers of disease severity don't also correlate with fatigue. So this is not just ITP and the platelet count not correlating. When we look at other conditions, it's not always that our laboratory numbers or disease markers that we know correlate well. And no studies have really linked the cytokine response to treatment to fatigue, or even looked at cytokine levels in relationship to fatigue. And we don't do that clinically. We're not sitting and checking cytokine panels on patients at the same time as we're checking their platelet count. So again, we have part of the story, but maybe not the whole story. This may also be why we don't see a change with the TPORAs with regards to fatigue. So they're not inherently adjusting the immune system or directly adjusting the immune system or these inflammatory markers. And so perhaps that's one example of where immunosuppressive therapy may have an effect that we're not seeing with the TPORAs. Again, I think without the data on the labs to look at that, it's really hard to know. And as I stated earlier, it's possible that patients who don't have a platelet count response are still having some suppression of an important cytokine or an important process that's driving their fatigue, and vice versa. So really important that we continue to not just look at the platelet count when we get information to tell us how patients are doing, because we may miss a drug or a treatment or a therapy that, even without platelet count changes, has some other change that's really impactful on patients living with ITP. As I say, some therapies may work against us. Sometimes we don't want to have a patient on therapy that's actually worse than living with the disease. I always say that to patients. That's not my goal. My goal of giving you therapy is never to make the therapy worse than how you were living with ITP off therapy. So corticosteroids, we've talked a lot about, and again, you all are by far more the experts on this than I am of what it's like to live on chronic steroids with sleep disruption, the way they make your body feel. And I think it's important to know this is likely under-recognized by physicians. There was a really nice survey that the Oklahoma group did showing, looking at worry about different aspects of having ITP, and the physicians were very, very focused, and their responses were much more geared towards bleeding symptoms and worry about bleeding, whereas patients expressed that their biggest worry was the way they were feeling on corticosteroids, the depression they were feeling, the change in how their body felt was far more important to them. And so we have this disconnect in what physicians are looking at and what patients are experiencing. And we really have to learn how to bring that together better, because only then can we start to address the complex nature of things such as fatigue. Some of our drugs lead to anemia through just suppressing the bone marrow. So the bone marrow is the factory where all the cells are coming from. And if a drug works by suppressing any part of that as a side effect, then the red blood cell production can go down from the factory, and that can lead to anemia. And we've talked about that can directly affect fatigue. L-thrombopag, there's been some case reports, can induce an iron deficiency anemia. So that's something that physicians and patients on L-thrombopag should be aware of. And iron deficiency, even if not leading to anemia, has been linked to fatigue. So important to recognize. And then there's some data about immunosuppression in general, unclear as to why, but drugs like rituximab, actually patients who got rituximab reported fatigue as a side effect greater than those getting standard of care or placebo. So I think, again, recognizing that treatment doesn't always have positive effects in the absence of something negative. And if we're treating in hopes of improving fatigue, we want to make sure that our treatment isn't actually going to then make that symptom worse. So I want to end by addressing management. And like I said in the very beginning, sometimes I think as physicians, we're uncomfortable talking about symptoms for which we're not then really sure what we're going to do about them or how to handle them. And I like this. This again came from the chronic liver disease literature, but it's called the TRACE approach. And in this approach, it's really sitting down and talking with patients in more detail about their fatigue to identify everything that could be contributing. So, we just did a huge discussion on all the different components. You saw that very complex kind of diagram, but it's really going through each of those components with a patient, whether using a specific measure for things such as depression or just generally more open discussion to identify those things that are treatable. What can we treat? What can we ameliorate? What are some symptoms or some causes that maybe we can come up with a coping plan for in terms of lifestyle changes? And then really it's a push, and this is why I like it. The push goes back to the physicians to really empathize with patients, not sympathize, but empathize and really sit with them and understand what they're going through, what fatigue means to them, and how to best accomplish a partnership in addressing it. So to treat the treatable, the first step of this is to exclude alternative causes of fatigue, whether or not they're secondary to the ITP or an entirely different condition. So looking for other causes for anemia, perhaps, or thyroid disease, celiac disease, so other autoimmune type situations, vitamin D deficiency, iron deficiency we talked about, restless leg syndrome, which sometimes can go along with iron deficiency and cause poor sleep at night. And these are treatable. These are all things where once identified, you can treat and perhaps then improve the fatigue symptoms. To ameliorate the amelioratable is to provide specific management for poor sleep, any vasomotor dysfunction. So I mentioned that dysregulation, that sort of changes in blood pressure that can lead to fatigue and is treatable. Depression and anxiety, if that's uncovered to be part of this. All of these are things that we have management options for outside of just providing treatment for the ITP. And even if we're not comfortable managing these things, then it's identifying the right provider to assist us to work as a team to support the whole patient. With regards to coping, it's to engage in discussions about fatigue. So possible external sources of fatigue, lifestyle changes. There's a lot of work done with graduated activity schedules. So slowly, incrementally increasing activity throughout the day. Actually, while thinking about it while you're tired, doing activity can sometimes give you back some energy. And so kind of retraining that pathway as well to recognize where our exertion point is. So graduated activity schedules, and then maintaining social structures, making sure that we're doing everything we can for our patients to support them in the goal of maintaining those social structures. So what is it that's preventing them from doing X, Y, and Z, and how can we help them achieve that in some way? And then lastly, like I said, it's providing that empathy. It's really sitting and listening with patients, because I think fatigue, no matter how many measures we come up with, the heart of fatigue is going to be different for every patient, and it's truly complex. And I think that we can measure it. I think that's good in helping to better understand it, to study it. But really, when the patient's in the room, it comes down to sitting down and having this discussion. And I encourage all of you to really openly talk about your fatigue with your physicians, to engage in these kinds of conversations, to make sure that everything's being done to address any possible sources of the fatigue. In conclusion, fatigue in ITP is real. Clinical trials should include assessment of fatigue as a patient-related outcome of importance. And I think using specific measures, not just general measures of quality of life, but really fatigue-specific measures now that we have them. The cause of fatigue in ITP is poorly understood, but likely has many causes, and we need further studies and information to really understand what the root cause is. On a chemical level or a biologic level, and then also understanding again from patients what external things may be contributing to fatigue. And then we need to pull from what's known about other chronic conditions. We don't have to work in the silo of ITP if a lot of work is being done in other conditions as well. Because as I said, it may be that this is a common symptom of chronic illness, not necessarily specific to ITP, that we can learn from. And it may be a little different in ITP, but I think it's important to always look at what's going on in the community as a whole. And then application of the TRACE model to address fatigue can improve comprehensive ITP care in a really meaningful way. So I'd like to conclude there, and thank you all for your time today, and I hope you're enjoying the conference.